Hello, everyone. Welcome to the March episode of the IJA Authors Podcast. I'm your host, Dr. Gayatri Sasikumar, and I bring you interesting topics once again that we'll be discussing on the podcast today. To start off with, as always, I'm going to welcome our editor-in-chief, Dr. Rakesh Garg. Dr. Rakesh, welcome to the podcast. So what is happening in the March issue of the IJA?
Thank you so much, Dr. Gayatri, for yet another informative episode of Indian Journal of Anesthesia. And at the outset, I would like to wish everybody International Women's Day being celebrated. And this issue also highlights the importance of our women anesthesiologists across the globe who has been doing multitasking from various fronts, personal and professional. And with the addition of an editorial which comes into the March issue, which very proudly, and it's a good moment to say that Indian women anesthesiologists are not less even in the research aspect. The publications coming from the various arenas across India in anesthesiology, a good representation from them. And I'm sure that we all together will bring forward this good research in various fronts. And in addition, again, March issue is bringing yet very many different aspects of anesthesiology, starting from the issue of opiate-based anesthesia versus opiate-free anesthesia. Probably we need to think of something opiate-sparing anesthesia. And in this context, yet few articles has been talking where the regional blocks have expanded their horizons for providing the perioperative care. And not only this, when we talk about the opiate-free, we also are talking about the airway management tools. We are looking for the safety from airway management tools, and that's why the IJA issue also has certain safety concerns, wherein the use of these newer airway gadgets has been incorporated into various practices. We know that transesophageal echo is emerging. It has many beneficial effects, but to improve further safety, can we use video laryngoscope for transesophageal echocardiography? Yes, probably. This article highlights into that aspects also. And when we are looking for the safety profile, we are using technology, and authors have reported yet another article where the electrical cardiometry has been used to look for that what is the effect of different volumes of the local anesthetic agent into the caudal blocks and how do they affect various aspects. We do talk about drug-induced complications. In previous issue of IJA, we have talked about drug errors. And this issue of March brings about very important article when we talk about etomidate and myoclonus. Yes, etomidate is good, but myoclonus associated with is also of a concern. How can we reduce it? Are there some factors of its administration? The IJA March issue again highlights this aspect. And similarly, various airway blocks, various regional blocks, airway management thing comes into picture. And bringing the technology as IJA is using it, we have been using the digital mode, digital health. Can this smartphone application be beneficial in the perioperative period? Let's again see in the IJA March issue whether they are helpful for pediatric surgeries wherein the patients, the children have a lot of anxiety. And then again comes the more newer modalities when we say point of care tools like ultrasonography. Can they be used for assessing certain predictors? Can they be used for some dynamic management? Again, IJA issue highlights it. In addition, a lot of interesting short notes in the form of letter to editor is being highlighted in the Indian Journal of Anesthesia. I think this compendium will bring to the readers a wide array of various concerns, various tools and technologies, various monitoring aspects to improve a patient outcome.
Yes, thank you, Dr. Rakesh. As you said, the March issue is a really interesting read. It's got a wide range of topics, and like you mentioned, the use of opioid-free anesthesia. Today we have two regional anesthesia topics that we're going to discuss. And thank you very much for starting off with the wish for the International Women's Day. I'm going to quickly jump in and invite our first author. Excited to have him here. There was a prospective observational study published in the March issue of the IJA, This is on ultrasound evaluation of palatoglossal space to predict difficult mask ventilation. And to talk about this, I have Dr. Pankaj Kundra. He's a professor in the Department of Anesthesiology and Critical Care, JIPMA, Pondicherry, and he's the Dean, School of Medicine, Pondicherry University. Dr. Kundra, welcome to the podcast. I'm really excited to have this conversation with you.
Thank you very much, Dr. Gayatri and Dr. Rakesh. It's a pleasure to be here.
Dr. Kundra, I was reading your article with interest. You've done a lot of work on ultrasound of the airway. So I'm curious to know how the palatoglossal space assessment fits into the existing landscape of airway focus, and why did you choose this parameter, and how does it compare with other ultrasonographic predictors of difficult airway management?
Fine. Thank you, Dr. Gayatri. It's a very pertinent question. Now, the way this idea came to us and we formed into a research question was that airway assessment, all of us are aware, is done by Mallampatty's classification. And Mallampatty's classification, if you look at, if it is grade 4, you will only be able to see the soft palate and you will not be able to visualize the posterior pharyngeal wall. But the problem was that the patient has to stick out the tongue, open the mouth wide, so that you could visualize what is the relation of soft palate and the tongue to the visualization of posterior pharyngeal wall. Now, with ultrasound, you don't have to ask the patient to open the mouth or stick out the tongue. You can visualize the interior of the larynx and the pharynx and see their relationship. So that's how this idea propped up. So we did initially the ultrasound examinations. I performed many of them, maybe about 500, 600 of them. And then we also correlated with the MRI pictures and validated what we were seeing. So it was a good idea to see that if you can just see with the patient who is going to lie supine during the induction of anesthesia, not opening his mouth and taking out his tongue, that's the way we are going to induce. What will happen to the space which we are trying to visualize, whether it's an open space or is it a closed space, and we'll need to use an adjunct to open up the space. So that's the idea we worked upon to give us a fairly good idea bedside to see whether there's going to be a problem with mask ventilation.
So your study found an impressive sensitivity and specificity for the palatoglossal space in predicting difficult mask ventilation. So how do you think this compares to traditional predictors of difficult mask ventilation, like, diff mask, or even when you're just doing clinical examination for the patients and say, okay, this looks like a difficult mask ventilation?
So, Dr. Gayatri, what diff mask scores and others are the composite scores, You'll have to look into various parameters where you come to a scoring system. So this is a single score, single visualization parameter, whether the space is obliterated or it is not. That's all we need to see. We don't have to take the calibers and measure anything. And the reason why it gave us a very good sensitivity was, we just try to make sure that do we need an adjunct to open up the airway, like a oropharyngeal airway or a nasopharyngeal airway, when you're not able to do mask ventilation. So it was not that after putting the adjuncts, you are not able to ventilate the patient. So it was a preparation to have your gadgets ready, that if you need such adjuncts, they should be ready, because the space doesn't look good, doesn't look patent. So better to have these things available. And if you're not able to mask ventilate, you will have to use one of these adjuncts to open up the airway to establish face mask ventilation. That's the reason our sensitivity and specificity are on a higher side, because we didn't define difficult mask ventilation as after the insertion of these aids, and then we try to mask ventilate. It was a preemptive move to see whether we will require these aids to open up the airway so that we can establish face mask ventilation.
Dr. Kundra, do you think this parameter can be used as a threshold to help us decide whether a particular person probably needs an awake intubation, and let's not even go ahead and I'm just trying to think, maybe, not even a oral airway is sufficient. You might have to start off with a supraglottic device. Can we be using it further to see that also in obese patients, if there is an obstruction of the space, would it be helpful in helping us decide if we need the CPAP for induction of anesthesia?
Precisely. So we are already embarking on a pilot project. I think it is going to be done in Singapore, because I've involved multiple people at in different countries across the globe. So in Singapore, there is a sleep lab. And when these people come, obese people come for a sleep study, we are trying to see how it correlates in those kind of patients. So that's a future research which we are embarking on. And also in children. I think Dr. Ahalya, we have talked about it. She's in Washington University. So I have shown her the space, and she's trying to evaluate in kids. How does this space become significant in children when they are being placed in supine position just before induction? So these are future ideas where future research has to come across. And I'm sure we'll have some good indicators when we complete these studies, which are already the pilot studies are taking place.
I think you did mention, but I want to just ask you once again for the interest of the listeners, was this ultrasound performed in the supine or the sitting position? And
supine
do you think
position.
the position is going to affect?
Supine position. Supine. Yes, it does.
It should
supine
ideally
position.
be performed in the supine position.
Yeah, ideally in the supine position. But you can even look at the space, because it is just looking at the space. You can have the patient sitting upright and then again put them on supine and see it again. So that can also be a different kind of a correlation if you want to look at it. So what I want to specify is that palatoglossal space, just identification whether it is obliterated or not, makes a huge difference in how you perceive the patient would behave when you anesthetize it. So yes, you can do it in the upright, then place the patient in supine and then again revisualize and see if there is a difference. But in this study, it was done in supine position.
And your results also show that you also compared tongue thickness and found that tongue thickness had a lower sensitivity and specificity. But do you think that tongue thickness and palatoglossal space can complement each other? If do we continue measuring tongue thickness, or you think palatoglossal space is going to replace the value of tongue thickness measurement?
So, Dr. Gayatri, there are two things. Tongue thickness, where are you going to measure? It's a 3D structure. An ultrasound doesn't give you that 3D evaluation. So if I do a 3D ultrasound, maybe I will come with the right figures. So that's the reason at that particular space, when we were looking at the tongue thickness, placing the probe between the two condyles here, probably that didn't give you a proper tongue thickness which you want to look at. Because if you want to look at the volume of the tongue, that would probably be a better indicator to correlate rather than just looking at the tongue thickness. Because it's not only tongue thickness, it will be a small mandible, where the tongue, which is normal, is anatomically large. And the space and finally it would reflect onto the palatoglossal space. So palatoglossal space reflects the space available within the palate and the tongue, where you normally would try to see the egress and ingress of the air or the positive pressure ventilation.
Dr. Kundra, when we have emergency cases like where we need rapid sequence induction, do you think the PGS evaluation can be integrated into the evaluation of difficult airway because of the time that it probably takes to do the ultrasound?
Yeah, of course, because it doesn't take any time. If you have the ultrasound with you, you just put the probe there, see whether the palatoglossal space is open or it is obliterated, and then it roughly gives you a guide that yes, before you, when you do the apneic oxygenation, you must make sure that an airway is inserted so that there is any sort of obstruction which is in the upper airway would not hinder the oxygenation of the patient even when you're not trying to ventilate that. So it tells you about the upper airway obstruction, and the most commonest area is between the palate and the tongue.
You spoke about people doing study of the PGS in pediatric population and the Singapore study that they're planning on obese patients. Do you think any other patient category would really benefit of this? Or do you see that? Do you see this going to be used as a routine application in the evaluation of difficult mass ventilation anesthesia?
Dr. Gayatri, the only thing I'm hopeful is that it's a very easy way of evaluation, because all of us know that it's not the laryngoscopy or intubation, it is oxygenation. So the oxygenation of the patient should not be compromised, whatever said and done. And the effective oxygenation starts from to make sure that the oxygen flow is not obstructed. Even if it is a difficult intubation, if you're able to oxygenate, your patient is safe. So the emphasis is that how can we maintain effective oxygenation when the patient is put to sleep. So I feel that this parameter would definitely help people to do it bedside. You don't have to make any measurements. All you have to see is whether this space is obliterated or open. That's all. And if you find that, you are at least prepared that yes, if it is obliterated, we should better put in an airway after the induction dose is done. And even for rapid sequence induction, continue once the airway is opened up. So that's how I see it. See, we talk about head extension. Has anyone measured the angles? No one has measured the angles. Right? When we talk about mouth opening, no one takes a scale to see how much is the mouth opening. What we normally see is just use our fingers to see how much is the mouth opening. So something which is easily reproducible and can be easily done at bedside would be effective. Rather than taking distances, trying to see how does it correlate. So that's a labor-intensive effort, and there is a lot of inter-observer variation in that. So that's the purpose of the study, to make sure that it is used as a focus or a point of care where you defined a particular question, whether you would require an airway adjunct to mask ventilate or to oxygenate. That's the question you need to answer. And the acquisition is done with a transverse view. If you're not comfortable, you can even use the sagittal view to look at it. So both the views can be done, and it's a fairly easy way of doing it. So the amount of workshops of ultrasound I have conducted, I've always used volunteers. So I would have used about 400, 500 volunteers till date, because every time I don't have a volunteer sitting there and people doing at that, I pick up a volunteer from the delegates and I make them sit there. So for a group, there will be 2-3 people who will be sitting, and 5 times if they rotate, even in one workshop, I'll be screening about 15 of them. So I'm pretty confident that it would be a good a good tool to assess the airway, whether you will be able to oxygenate, oxygenate the patient with.
Yeah, absolutely correct. I think, Dr. Kundra, I always see this, especially when teaching students. Many a times when we're doing the surgical safety call out, or when the nurse asks them, is it a difficult airway? They say no. And then after having practiced anesthesia for a few years, you kind of look at a person's face and it is a difficult mask ventilation. So like you rightly said, when you have something like an ultrasound, which shows even to a novice that this is going to be a difficult mask ventilation, I think that is a good way forward in terms of patient safety.
Yes.
So, Dr. Kundra, you've done a lot of work in ultrasound. I want to ask you one last question. What do you see as the next frontier in ultrasound assessment of the airway? Do you have any new parameters that you're looking at, or do you think there's any parameters that you want to look at?
Yes, there are many. I think I have almost 5 studies lined up, and we'll come up with those results very soon. So, and it will all be focused towards point of care assessment of the airway, so that people can practice it readily and it is not too difficult to acquire the images. So the one which made me interested in this airway ultrasound was the case report which we published in about 12, 13 years back in anesthesia, where we looked at the vocal cords after thyroidectomy, whether the movements were bilaterally symmetrical. And incidentally, we picked up there was a vocal cord palsy, and we published it. And every time I take a lecture, I emphasize, please do not do direct laryngoscopy in awake patients where residual neuromuscular blockade has been reversed. It is just absolutely the opposite when you do it in a completely anesthetized, paralyzed patient. And that also to have a 2 or 3 second view. So I think all of us should practice this, that make sure that this unethical practice of doing laryngoscopy in a patient after thyroidectomy when the patient is awake should be abandoned. You can do a nasal fiber optic scopy if at all you're not comfortable with ultrasound, but ultrasound is the least invasive. You can easily pick it up, and all that you do is to document. Second thing is, which I'm working on, is the stridor part. Now, how to predict post-extubation stridor? So that's another area where we are working on whether there is a air leak around and how can we detect an air leak with the ultrasound. The third area is whether the cricothyroid membrane actually marking it makes it relevant when you actually want to do a cricothyroidotomy. Our sample size is large. We have already completed about 80 patients, and our interim analysis tells us that it is no use marking the cricothyroid membrane because the structures which you perceive when you had marked would not be at the same site when you have marked it. So there's a huge difference, and hardly any patient we could pick up the cricothyroid membrane where we had marked pre-induction when we had anesthetized and seen, because there's so much of manipulation of the head and neck which happens, and this surface marking doesn't help. Then to go forward, looking at the thyroid scan, do we need to do a PDT or a surgical tracheostomy? Because if the isthmus is covering the tracheal rings and you try to do a blind or you try to do a PDT, you're going to go through the substance of the thyroid gland, and which is going to cause a lot of inflammation and damage to the thyroid tissue. And we do not know how long that tracheostomy tube is going to lie. Fourth is looking at the cuff. Where is the cuff positioned? So there are so many things which I want to do, but let me see how much we can produce in the coming years.
Wow, that's wonderful. I'm looking forward to the results of all your studies, Dr. Kundra. Thank you once again for joining us on the podcast. It was wonderful talking with you and listening to your ideas of the various parameters that we can assess in ultrasound of the airway. I'm sure the listeners will truly find this interesting and informative.
Thank you so much. Thank you so much for giving me this opportunity.
So after the first very interesting topic that we discussed, I'm going to talk about segmental spinal anesthesia. And this is a topic that has been, appearing in a lot of journals. There's a lot of interest around this. And this issue of the March episode of the IJA podcast also has a case series on segmental spinal anesthesia and high-risk obstetric pregnancies. And to discuss about this, I have Dr. Naresh Paliwal. He is the know-all of segmental spinal anesthesia. He's a professor emeritus, DRPD, MMC, Amravati, Maharashtra. Dr. Naresh, welcome to the podcast.
Thank you. Thank you for inviting me. I am very much thankful to IJ, Dr. Rakesh Garg, and Dr. Gayatri, Sony, and also Dr. Suvarna Kaniyal, who presented the case series in the IJ. She is from GMC, Calicut. So, thanks to all of them.
Dr. Naresh, my first question would be, why did the concept of segmental spinal anesthesia arise in the first place?
Actually, when I started my practice some 35 years back, I started working at a very remote place. It is near to the tribal area, where most of the patients, they come very late. I mean, they have duodenal perforation, obstruction, and all sorts of abdominal emergencies, and they come very late. Some 4 or 5 days old perforation with bilateral pneumonia and everything. If you don't operate them, they will take them home and let the patient die. So in such cases, initially I used to use the full 4 ml of the drug, but still the effect was not up to the mark. I mean, the levels were not reached and there were a lot of hemodynamic fluctuation. So gradually I started doing some high spaces with lower doses, around 2000. So that time, actually, to be very honest, I was not knowing this concept of segmental thoracic spinal anesthesia. But when I saw the literature after 2007 or 8, I started presenting about this and the availability of the more safer drugs like levobupivacaine, ropivacaine after that, and the additives made it more safe. I started presenting since 2011, and now, as you all know, it's it's a red hot topic.
So when we were taught conventional spinal technique, the attention was always given to getting the needle at a space below where the spinal cord ends to avoid the risk of injury to the spinal cord. So how do you make sure, isn't, when you're doing higher thoracic spinals, is there no risk for spinal cord injury?
That's the main concern whenever we talk about thoracic segmental spinal anesthesia. But on the other side, the thoracic epidural is being performed day in and day out, even by the trainees. And, at times there is accidental dural puncture, and still the incidence of neurological complications after that is very less. And there are many reasons for that. First thing is the spinal cord is positioned anteriorly at the mid-thoracic and low thoracic levels. There is sufficient space between the posterior dura and the spinal cord at this level. And when you ask the patient to sit and flex the spinal cord sits ventral in the apex of the thoracic curve. That also makes distance from the posterior dura, while this space is not there in the cervical and lumbar region. And also, because of the angulation which is needed to perform spinal at mid-thoracic levels, the distance between the posterior dura and the spinal cord is further increased. There are so many reasons why, but still you need to be very gentle while performing spinal anesthesia at these levels.
So you just mentioned about the spinal cord being in the more anterior level in the thoracic space, and you said the sitting position makes it, move forward more anteriorly. So do you typically perform these blocks in the sitting or in the lateral position?
Yes, actually, Lee R.A. did a study about the position of the spinal cord in various positions, supine, lateral, and sitting, and he found the position to be more anteriorly in all positions, supine, lateral, and sitting, more so in the sitting position. And sitting position is used by most of the anesthesiologists, and it's more comfortable for anesthetists. But lateral position can very well be used. I am accustomed to using lateral position, so I use that. But sitting is more preferable because the landmarks are easy to palpate and it's easier to, because of the increased CSF pressure, can look at the spaces.
So Dr. Naresh, it's obvious that the segmental spinal anesthesia, because of the lower dose we're giving, has a advantage over the conventional spinal anesthesia because of the lower sympathetic response. But what other specific advantage in your clinical practice have you noticed with segmental spinals, especially in high-risk cases?
You see, the surgeries, actually the upper abdominal and thoracic surgeries, what people used to do, they used to give almost double the dose, around 4 ml of the dose, but still the adequate levels were not reached, and it is not possible to do even upper abdominal and thoracic surgeries. But here, with just half the dose, then that is used at a lumbar levels, you can do all these surgeries. There is also lumbosacral sparing, less venodilatation in the lower limbs, the right atrial filling is maintained, and also because of the use of these isobaric drugs, there is more of a preferential sensory block. So there is early recovery, voiding, and most of the time you don't need to catheterize the patients even for upper abdominal surgeries. The recovery is very good. These are other advantages apart from the hemodynamic stability in very high-risk patients. And there are few other modes of using segmental spinal. It's not just a single shot. You can combine it with epidurals. You can combine a two-drug technique. You can have this continuous segmental spinal anesthesia. So according to need, you can use the mode of segmental spinal.
When we talk about high-risk pregnancies, like how it's written in this article, the case series that was done, they did a segmental spinal. But when we used to discuss high-risk pregnancies, we talked about graded epidurals. So how do you compare graded epidurals with segmental spinals?
Yeah, you see, especially for LACS patients, there are very many options. Segmental spinal is one of them. The graded epidural, as you said, is one of the options. But the problem with graded epidural is it takes some time for onset. It requires a very large amount of drug, around 15 to 20 ml at least. And it can have some patchy blocks, especially when there is some deformities or that. And even after using 15-20 ml of the drug, still can have some lumbosacral sparing. So patient may need sedation or patient can have discomfort. So ideally, what you can do is you can combine the epidural along with spinal. Either use a low dose of hyperbaric drugs, or you can combine two drug technique. Just like in the case series, what we did is we combined the advantages of all the techniques. Just a little hyperbaric drug to cover the lumbosacral segments. Just the patient should not feel any pain during pelvic manipulations, during the baby extraction, and enough dose of isobaric to have a segmental epidural-like effect to cover the other segments. The advantage of using isobaric drugs along with hyperbaric drug is it has an early onset, a dense uniform block, and the rest of the things can be covered with epidural. Epidural can act as a backup. I mean, if the levels are not achieved, you can use the epidural titrated doses, and also useful for post-op analgesia. So you are combining advantages of all the things together.
That is interesting. Actually, my next question to you was that I saw that they mixed isobaric with hyperbaric, and you explained to us why this is so. Is there any other, mixture that you use which is probably surgery specific?
Yeah. Actually, what happens when you use a low dose of isobaric drugs at low thoracic or higher lumbar levels? What happens? There is some lumbosacral sparing, just like your epidurals. So combining with hyperbaric drugs, you can have both these, cover the lumbosacral segments just to your requirements. It's not a very dense block, but it works very nicely. And because of this low dose, patients can have this hemodynamic stability. The other combination we can use is hypobaric with isobaric, especially for laparoscopic cholecystectomies, where the patient is kept in a head-up position. What you can do is you can use just 0.1% 2 ml of the hypobaric drug, that is just 2 milligram initially in a different syringe, and then you can use your isobaric drugs around 1.5 to whatever is requirement up to 2 ml of the drug at around T10 level. 10 thoracic space is usually the center of the surgical field for upper abdominal surgeries. You can vary your space a little bit and you're in dose. So this combination hypobaric with isobaric can work well for your laparoscopic cholecystectomies to avoid the shoulder tip pain. The hypobaric drug usually covers the cervical segments, and your isobaric drug will have effect up to T3, T4. That is needed for laparoscopic cholecystectomies. So there are various permutations and combinations you can go with.
Okay. So you use different combinations, but you do not mix them. You use them.
No, we don't mix it.
syringes.
We use a different syringes for giving these drugs, and you can add the additives. Like if you add fentanyl is hypobaric, and if you add it to isobaric drugs, it will make it slightly hypobaric and have a desired effect. I mean, you can have higher levels of block adding fentanyl to it.
Yes. So, could you share your criteria for selecting patients for SSA? And what are the key clinical indicators or red flags that suggest that segmental spinal should not be attempted even in high-risk obstetric scenarios?
See, the segmental spinal, the indication of segmental spinal needs to match the surgical needs of the patient. This is what we do. And according to the surgeon, surgery, and the comorbidities, we can choose our mode of segmental spinal. Right from thoracoscopies, we have done many cases of thoracoscopies, of superficial thoracic surgeries, even MRM and all this, we are doing routinely. Then upper abdominal surgeries, they all can be done, even for lower abdominal surgeries, major surgeries. You have different modes of anesthesia, single shot segmental spinal for short to mid duration surgeries. You can combine with epidural. In epidural also, you can use it as a top-up you can use epidural volume extension technique to spread the low dose intrathecally to wider segments. Then the third option is continuous segmental spinal. In case you have accidental dural puncture, you can use this mode. Or in very high-risk patients, this can be a primary mode. Like patients with severe aortic stenosis, it is even mentioned in some books, standard books, that continuous spinal can be used as a mode of anesthesia for very high-risk patients. And the red flags, actually the patients having all the contraindications for spinal, or also for this, patients having some coagulation abnormalities, or patient's refusal, or even surgeon not willing to, don't force your surgeon to do it under segmental spinal. If there is strong indication, you can convince him. Also, the superficial neck and upper extremity surgeries are possible under segmental spinal. I mean, there are reports of it being done, but we usually don't advocate that, just because there are less invasive and more safer blocks available, superficial blocks available for these surgeries. Also, nowadays what happened, people are knowing how to use this segmental spine, and they are using it for very minor surgeries like removal of fibroadenoma of breast. I mean, it becomes an overkill for such procedures. For simple surgeries, you need to balance the things. You should have a strong indication in favor of doing that. And also in pediatric patients, we have done a lot of pediatric patients in segmental spinal, and we usually don't advocate it to do unless you are well versed with other aspects of your pediatric spinal anesthesia. You should be well versed with the airway management and other things in pediatric anesthesia, then only you can venture this.
I think what you said now is very important. I think whenever we learn something new, I think it's very important to also know, even though you know
When
it,
not to
you're
do it.
excited about it, you should know when not to do it. Especially when you talked about upper extremity surgeries. When we have blocks that work, it doesn't make sense to do a segmental spinal just because we are excited to do it. Thank you very much for that, Dr. Naresh. Before I end, I want to ask you if you have any tips for those who are wanting to start doing segmental spinal, any technical aspects, any difficulties that you've met with, and over time that you have, made them better.
Yes, you can, to start with, you can start with very superficial surgeries like umbilical hernia, epigastric hernia. These are very superficial surgeries, and you don't have to go very high. Because low thoracic spaces is as good as your lumbar spaces. There is not much of angulation, and they are easy spaces. And you can use just isobaric drugs around 1.5 to 2 ml, and that's all. You can use the additive according to your need. Dexmed nowadays we are using is a very good additive and can provide you duration almost up to 3 to 4 hours. Depending on the surgical needs, you can use from 2 to 10 micro. So to begin with, you can start with such simple surgeries. And at mid-thoracic levels, it is slightly difficult. I mean, because of the angulations of the spinous processes, and they are not always in the straight line. They are undulating. So you need to be accustomed to either thoracic epidurals first before trying to your spinals. Like for MRM patients, we advocate doing it at mid-thoracic levels. But it's slightly difficult. Even at this stage, we find some difficulties at times in performing spinal at mid-thoracic levels. You can take the help of ultrasound if you have that facilities available. That is very good. You can do a pre-procedure scan, mark the depth of the interlaminar space and direction of this thing, which space is more open. You can see that.
Thank you very much, Dr. Naresh, for joining us on the podcast and sharing your experiences with the segmental spinal. And I'm sure that all our listeners, especially the young students, will be really interested in listening to what you have to say. Thank you once again.
Thank you. Thank you very much for providing me this opportunity. Once again, thanks.
So after this very informative conversation with Dr. Naresh Paliwal, I'm going to now talk about a case series that was published in the March episode of the IJA, which spoke about enhancing recovery in cervical spine surgery with erector spinae plain block. And to talk about this paper, we have Dr. Sony, who's an anesthesiologist who currently works at AIIMS Deoghar. Dr. Sony, welcome to the podcast.
Thank you, Dr. Gayatri. I would like to thank Dr. Rakesh Garg and the entire team of IJA for providing me this opportunity.
Dr. Sony, your case series describes using the ESP blocks for cervical spine surgeries for anterior discectomies. So I'm going to start off. When I was reading this, I was just wondering, are anterior discectomies actually very painful enough to warrant regional blocks?
So the anterior discectomies or discectomies with fusion surgeries are usually moderately painful. It's not of severe category, but it's of moderate in nature. And there are studies which say that the immediate post-operative pain translates into long-term pain outcomes. So if the post-operative pain is well managed and the patients who have lower post-operative pain scores, the 1 year or 2 year even follow-up, they say that the longer chronic pain, the translation of this acute pain into chronic pain is very less. Approximately about 1% patient will experience chronic pain if the post-operative pain is very high. And these patients who undergo these surgeries, they have been living in chronic debilitating pain. They chose for this surgery. They opted to undergo this surgery, and their expectation that after the surgery, their pain will go and their quality of life will improve. The expectation is quite high. So
Yes.
that part is also there, not just the VAS and NRS, which is measurable, but also the psychological and emotional aspect of the pain. So that's why the post-operative pain is very much important, not
Yes.
just for us, but for the patients
Yeah.
also.
So just not to talk about numbers, but it's also the individual patient's perspective and their emotional expectations of how pain is managed post-operative. You seem to have chosen the T1 space for performing these blocks. So what anatomical landmarks did you use to identify the space, and why is this level optimal for cervical spine surgeries?
Also, Dr. Gayatri, we scanned the T1 spinous process, and from there we translated to identify the first costotransverse junction, where the first rib attaches to the transverse process of T1 vertebra. So that was our anatomical landmark, and it's very easily identifiable in ultrasound. And it's a very superficial landmark. We don't need to scan deep enough. And at our center, we usually don't provide any regional anesthesia for cervical spine surgery. So we just started this, and we wanted to see what's the outcome and how well it translates into the postoperative period. And giving this block at the higher level, which other studies have been there at C5, C6, and C7, and so. So we were not that much confident to venture into the cervical space itself first, even though it's easier, but we wanted to have a definite landmark where we won't have to move the probe much to scan and count from that level to C5, C6, C7 level. To have a definite landmark where we don't have to move much, and for beginners like us, we could do it easily. That's why we chose T1 space. And as for how well it covers the surgical dermatomes and all. So there have been various case studies where they have seen in cadavers and in young adult patients also to see the spread of the dye, up till where the dye goes. So they have found that even in T1 level, if they give the dye at T1 space, it spreads up to C2. And the dye spread is not uniform and predictable. It can reach up to C6 also, and it can go beyond C6 up to C2 also. And even if they give the block at C6 level, sometimes the dye won't go up and it would reach up till C4 level itself. So the predictability is variable with the dye spreads, and there aren't many studies. Probably an RCT would come, which would tell us more about it, that how much and what level is definite and compared to different levels. So this is just our experience that T1 level is appropriate for covering the lower cervical spine surgeries, like up till C5. In our cases, we did for C5 till C5, C6 patient. So it was adequate.
Okay. And what was the duration of analgesia that you observed with these patients?
So in our cases, there were two subsets of patients. The one who required only single level of fusion, that those patients had a longer pain relief for up till 48 hours. While the patient who had dual level surgeries, their pain relief was up till 30 to 36 hours. That is post-operative day one, they were still pain-free. At 30 to 36 hours around, they needed some rescue analgesia. And therein we gave paracetamol as per the institutional protocol, like 1 gram single dose. So earlier in our institution, it was the protocol that whether the patient demands or not, continuous IV analgesia around the clock would be provided to the patient. So we just ask the surgeon to stop it until the patient asks for it. Don't provide any rescue analgesia. And we saw that at day one that nobody asked for any rescue analgesia.
So did you use any adjuvants?
Yes. So it was for cervical surgeries. That's why we used epinephrine, and we were using bupivacaine in larger doses, approximately 30 ml, 50 ml bilaterally we were giving. So the vascularity in this region is very high compared to the lumbar regions and thoracic regions. So we gave epinephrine along with it to reduce the uptake. And to prolong the duration of the block, we used dexamethasone.
You said the vascularity is higher in this region than in the lower thoracic and upper lumbar. Okay, all right. And you use dexamethasone 8 milligrams, right?
Yes.
Okay.
That
And
was
did you perform? Sorry, what is it?
That was for prolonging the duration.
Prolonging the duration. So did you perform these blocks prior to the surgical incision, or did you do them at the end of the surgery?
So we perform these blocks 30 minutes prior to the induction of the anesthesia in awake patients in sitting position. So we found that the patients were most comfortable in sitting, and as an anesthesiologist, we are also very comfortable in giving blocks when the patient is in sitting position. So it was comfortable for both of us, the sitting position. And prior to induction of anesthesia, we wanted to see how the pain relief is there. We were able to see, as we were the chronic pain patients, so immediate reduction in pain was there even before the induction of anesthesia. So we were sure about it that it's working. And that's why we gave it before induction of anesthesia. And the other reason was that we wanted to reduce the cumulative dose of opioid. That's why we gave it preoperatively.
So intraoperatively, you did not use any additional opioid?
Intraoperatively, we just gave induction dose of fentanyl, and we had kept rescue opioids if hemodynamics are unstable or the patient requires. So we would supplement it, but we did not supplement in any of the cases, as the hemodynamics were quite stable, and post-operatively also the patients didn't require any opioid supplementation.
I see that your case series had a wide range of patients in a wide range of BMI from 22.5 to 42. Did you observe any difference, technical difficulties in when the patient's habitus changes in performing these blocks?
So our study had around, I think one patient had 44 kg per meter square BMI, which was very high. And we anticipated that there might be difficulty in performing block in that person, but it wasn't the case. As the landmarks are quite clear, and it's, as I said, it's not a very deep block. So we were able to perform it easily in those patients also with higher BMI. Appears challenging whether we will be able to perform or not, but we didn't experience any such difficulty. maybe with habitus or patients having very large amount of subcutaneous fat, we might have to go deeper, but I think it's still not that difficult.
Have you used, so your patients were all anterior discectomies. Have you used them in posterior instrumentations as well? And has it been useful?
No, no. Actually, there have been all the previous studies are in posterior instrumentation. So ours was the one which wanted to explore the anterior discectomy.
Okay.
Because obviously in posterior discectomies, there is a lot of tissue dissection.
Yeah.
So it's going to be painful, which is less in ACPF, anterior surgeries. So in posterior, all the studies, all the RCTs which have been done are in posterior instrumentation. So I think there is, I won't say a good evidence, but emerging evidence is there that it's effective in the posterior instrumentation.
But maybe you need to add multimodal analgesia along with it to compensate.
So the thing is that the other surgeries in posterior instrumentation, they all had put catheters or had supplemented the block if they had given it prior to the incision. Post-operatively also, before waking up the patient, they supplemented one dose. So none of them had done a single shot and seen how it translates into the post-op.
So, Dr. Sony, I'm just interested to know now that you said you were looking at whether the anterior aspect is covered with this. So, I'm trying to think if there's any emerging evidence or clinical experience using the block, erector spinal block, for anterior neck procedures such as carotid endarterectomies or thyroid surgeries, and is there any anatomical landmark considerations that would influence its efficacy when compared to traditional cervical plexus blocks?
So when these cadaveric studies were being performed, so they did not only see the caudal cranial spread, they also saw how it translates laterally and anteriorly. So they found that usually the volume which were used was around 15 to 30 ml. Approximately 20 ml was kept as this must be the amount to see the anterior spread. And they saw that the carotid sheath was also getting stained along with the dye. So, one of the cadaveric studies, they found that some spread into the paravertebral, paravertebral layer is also there. So, which would affect the cervical plexus also, theoretically. So, there is actually one study where they have seen 12 cases for carotid endarterectomy. These Turkish investigators are there. They have seen it, and they have done it under just regional anesthesia. Out of 12 patients, around 3 patients, they didn't require any local supplementation, while other 9 patients had local supplementation by the surgeon itself. So there wasn't any requirement of general anesthesia in their case. But for thyroid surgery, I have not come across any.
So, did you have any complications while performing in any of your patients? Did you have any complications, or are there reports of any complications with this block for cervical
Actually,
procedures?
the electrospinal plane block is a facial block. So there is not much of neurovascular bundles or anything nearby, which would result into major complications. And we have not come across any such complications in our case, despite doing in the cervical issue. And I think it has been thought of as a safe block, which lessens the complication compared to the other blocks which are available compared to other neuraxial blocks or other facial plane blocks wherein the neurovascular bundles are there. So interestingly, like you asked, the upper thoracic and basically the cervical ESP blocks were first started for chronic shoulder pain and with the patients with undergoing shoulder surgeries, which later translated into whether it can be used into the perioperative period for shoulder surgeries also. Because ideally we would give a interscalene block or brachial plexus block or some other blocks wherein there would be involvement of the C5. So it has been found that it's a phrenic nerve sparing block if performed at C7 or T1 level. In a way, I would say that's safer than other uraxial as well as regional.
Thank you very much, Dr. Sony, for joining us on the podcast and sharing your experiences with erector spinae block. It has been wonderful chatting with you, and we're really honored to have you join us on the podcast today.
Thank you again, Dr. Gayatri. Thank you again, the entire team of IJA, for giving me this opportunity.
So, to our listeners, I hope you had as much fun listening to this podcast as much I had recording this one. So until next time, stay safe and stay curious, and we'll bring you more interesting articles and topics to discuss in the next episode of the podcast. Thank you very much.